Welcome to the Hospital Medicine Unplugged podcast. We're diving deep today into a persistent challenge that, well, it touches every single unit in every acute care setting, inpatient falls. And while sometimes we treat them as common, almost, inevitable events, the reality is that hospital falls are a leading and often catastrophic cause of preventable injury. This profoundly impacts patient safety, drives up patient suffering, and critically places a massive strain on institutional cost and reimbursement structures.
That's the core tension we need to address. The stakes, both ethically and financially, are just immense. Our mission in this deep dive is to synthesize the current evidence, guidelines, and new research to fundamentally shift our approach. We're moving away from reactive management, the investigation and cleanup after the fall, to proactive, evidence-based, multifactorial prevention strategies. We need to cut through the noise, identify the highest yield modifiable risk factors, detail the modern guideline-driven approach to screening and assessment, and, crucially, separate the interventions that truly work from the controversial measures that are either ineffective, resource-intensive, or, frankly, harmful.
Right. Our goal here is to arm you with the specific data and operational advice you need to transition your units from generic protocols to individualized high-efficacy care bundles. We are talking about preventing those extra 6 to 12 days of hospitalization, avoiding tens of thousands of dollars in unreimbursed costs, and most importantly, protecting our most vulnerable patients from these life-altering injuries.
Let's unpack this. We have to start by understanding the sheer scale of the problem we're facing.
Absolutely. Let's start with the baseline rates. Across acute care settings, falls are rampant. We see rates ranging from 1.5 falls per 1,000 patient days all the way up to 4.2.
And to put that into a clinical context, if you run a 100-bed unit, 4.2 falls per 1,000 patient days means you're managing 3 to 4 falls every single week.
Wow.
It's an unsustainable volume problem, and that variability isn't evenly distributed. If you're managing medical or geriatric units, you are consistently dealing with the highest rates, often hitting or exceeding a state mean benchmark of 3.99 falls per 1,000 patient days.
So that volume is what drives the injury problem.
It's the engine that drives it.
And the so what factor, the injury burden, is where prevention becomes a moral and professional mandate. While the overall injury rate is estimated at 0.4 per 1,000 patient days, something like 25 to 50% of hospitalized patients who fall sustain some level of injury, from minor bruises to major trauma.
And we must focus intensely on the geriatric disparity. This is where the risk is just exponentially amplified. Major injuries occur in roughly 9.5% of geriatric fallers, compared to only 1.2% of non-geriatric patients.
That is an 8-fold increased risk. Just staggering.
It is an 8-fold increased risk of a severe life-altering injury just by virtue of being an older adult in the hospital setting. And the nature of these injuries is predictable and devastating. 70% of major geriatric injuries are fractures. We are specifically trying to prevent the most serious sequelae hip fractures, which often initiate a permanent decline in functional status, subdural hematomas, and intracranial hemorrhages.
And beyond the immense morbidity, the financial consequences are just staggering. If a patient sustains a serious injurious fall, the length of stay increases by anywhere from 6 to 12 days. And when you calculate all the costs, acute care, rehab, investigation, the expenses for a single serious injury episode can range from $19,376 up to $32,215.
And that's where the regulatory environment applies massive pressure.
Precisely. This cost isn't just an expense, it's often an uncompensated loss.
Exactly. Falls with injury are classified as hospital-acquired conditions, or HACs, and are consequently deemed non-reimbursable under Centers for Medicare and Medicaid Services policies. So the hospital is not reimbursed for the care directly related to managing that serious injury.
It's a powerful financial stick.
It is. It complements our ethical duty to ensure we have robust, effective prevention programs in place.
And the regulatory weight is further cemented by the Joint Commission. They designate falls resulting in specific severe outcomes as sentinel events, which triggers a mandatory and resource-intensive systematic analysis.
And the criteria for a fall to constitute a sentinel event in a staffed around-the-clock setting are absolutely critical for hospital leaders to understand as they define our minimum acceptable outcome standard. A fall is a sentinel event if it results in any fracture. if it requires surgery, casting, or traction, if it necessitates consultation or management for a neurological injury like a skull fracture, subdural, or intracranial hemorrhage.
So any neuroconsult triggers it.
Any management for it, yes. Or if it requires blood product administration in patients with coagulopathy, or tragically, if it results in death or permanent harm. The moment any of these criteria are met, we are obligated to initiate a full root cause analysis and a documented corrective action plan.
So the primary objective is crystal clear and rooted in consensus across major bodies, including AHRQ and NICE. We must systematically reduce both the overall fall rates and the rate of falls with injury using dynamic, multifactorial approaches.
That systematic nature is key. Recent work, including a Delphi consensus, established a 42-item reference standard for prevention. It strongly pushes us towards sophisticated, tailored care, moving past those one-size-fits-all generic protocols.
Right.
This standard emphasizes brief screening on admission, comprehensive multifactorial assessment for high-risk patients, and the implementation of customized, individualized interventions based on the risks we identify.
Okay, so before we discuss those interventions, we need to clarify our language and typology. We need to know exactly what we are counting. So a hospital fall is defined as an unexpected event where a patient comes to rest on the ground floor or some lower level.
Right. And importantly, this definition specifically excludes intrinsic medical events like seizures, strokes, or an episode of syncope, which require a distinct, separate acute medical management.
Understanding the typology, the specific mechanism of the fall, is foundational to developing the right targeted prevention strategy. We generally classify hospital falls into three groups.
The first, and arguably the most common, is the anticipated physiological fall. These are predictable. They occur in patients who have known chronic risk factors, a documented gait disorder, established muscle weakness or sarcopenia, or known long-term medication side effects.
So if we've done our risk assessment well, we should be anticipating these.
We should be. The second type, and often the most challenging because it changes so rapidly, is the unanticipated physiological fall. These stem from an unexpected acute event that develops during the hospitalization itself. New onset delirium, an acute intercurrent illness like a severe UTI, or a sudden severe episode of orthostatic hypotension secondary to fluid shifts.
And these falls highlight the critical need for dynamic, shift-to-shift reassessment. A patient who was average risk yesterday might be profoundly high risk today.
Absolutely. And finally, we have accidental falls. These are primarily caused by environmental factors like a spill, clutter, or reaching for an inaccessible call light. While these exist, the majority of elective hospital prevention literature focuses far more heavily on mitigating the physiological classifications, as a hospital environment should, in theory, be standardized for safety.
And equally critical is the standardization of injury classification. We have to speak the same language when we're tracking outcomes.
We do. And for that, we rely on the National Database of Nursing Quality Indicators, or NDNQI. This system allows us to categorize injury severity into 5 levels, giving us the precision needed to track the most consequential outcomes.
We track none for no injury, minor for abrasions or bruises requiring minimal intervention, and moderate signifies injuries requiring a true clinical intervention like suturing, splinting, or initiating increased neurological monitoring.
The most critical part of this classification, the one that triggers the financial and regulatory alarms, is the major injury category. This includes everything from fractures to internal injuries or conditions requiring surgery. And within NDNQI, this major category is subdivided for even greater clinical precision.
And that subdivision tells the story of the potential resource drain. So major A encompasses temporary functional impairment, like a distal wrist fracture or a major facial injury without internal damage.
Right. These patients typically recover function fully, but they require significant acute resource deployment.
Then major B escalates the severity.
It does. This involves long-term functional impairment or a potential risk of increased mortality. Maybe a complex orthopedic injury requiring delayed surgery or multiple rib fractures that severely complicate pulmonary management. This category signals significant sustained resource use.
And major C is the ultimate severity, the category with the well-established risk of mortality and permanent disability.
This includes the classic outcomes we are desperately trying to prevent: a hip fracture, a subdural hematoma, or an intracranial hemorrhage. Understanding these classifications allows institutions to prioritize prevention efforts that target the mechanisms most likely to cause a major C event.
We also need to anchor our prevention efforts in context. The data tells us exactly where and when we need to focus resources.
The data is striking. Elimination-related falls are the single most common circumstance, accounting for nearly 50% of all hospital falls.
Let's unpack that. So these are transfers to or from the commode during showering or just rushing to the bathroom.
Exactly. They are overwhelmingly common in patients over 65 years old, and critically, they carry a significantly increased injury risk, documented at an adjusted odds ratio of 2.4 compared to other fall types.
An AOR of 2.4. So if half of our falls are happening around elimination, scheduled toileting and supervised transfer protocols have to be the #1 priority.
They must be. And beyond the bathroom, bed exit falls are frequent. About 85% of all falls occur within the patient's room, and 79% of those are unassisted.
So the patient attempts a sort of covert mission to get out of bed.
Right, often feeling ashamed or not wanting to bother the nursing staff, and this is where the injury happens.
And if we overlay the temporal data, ambulation falls frequently peak during the evening and overnight hours, accounting for 59% of all falls.
That temporal concentration, the 10 p.m. to 7 a.m. window, absolutely necessitates specific staffing models and monitoring strategies focused on managing acute nighttime needs.
This moves us firmly into the proactive phase, identifying and neutralizing the modifiable risk factors.
And at the top of that list, without question, are pharmacological agents. Medication review is not just a suggestion, it is the cornerstone of any effective prevention program.
Psychotropic medications are the strongest modifiable pharmacological risk factors. The risk associated with these agents is dramatic. When you look at the adjusted odds ratios, a measure of association between exposure and outcome, controlled for other factors, the numbers are impossible to ignore.
They really are. Benzodiazepines carry an AOR of 1.97, antidepressants an AOR of 2.25, hypnotic sedatives an AOR of 1.90, and antipsychotics an AOR of 1.61.
These aren't theoretical risks. They're mechanistic risks stemming from sedation, impaired cognition, and orthostatic effects.
And when we dive into specific classes, sedatives and hypnotics demonstrate an especially high adjusted ORR of 4.3.
0.3.
Yeah. High-risk agents also include first-generation antihistamines, such as diphenhydramine, atypical antipsychotics, and critically, medications used for diabetes, particularly insulin, which has an adjusted OR of 3.2, largely driven by hypoglycemia.
And of course, opioids, antihypertensives, vasodilators. All significant contributors.
They are. But here's where it gets really interesting. It's not just the individual drug, it's the cumulative burden. We know that polypharmacy, often defined as 4 or more medications, independently increases fall risk.
Right. And then there's the anticholinergic cognitive burden, or ACB score.
Exactly. Higher ACB scores, a system that rates drugs based on their potential to cause anticholinergic side effects that impair cognition, are significantly associated with serious falls.
The clinical implication is direct and actionable. Deprescribing is a high-yield intervention.
It is. Evidence supports a significant decrease in geriatric falls when psychotropics are safely eliminated or reduced. The challenge, however, is implementation.
That's where I need to push back on the operational reality. It sounds fantastic to say deprescribe psychotropics.
Yeah.
But how do you get buy-in from the psychiatry team or the primary service that is legitimately worried about the patient becoming acutely agitated or delirious if you abruptly pull their alprazolam or amitriptyline? This is a huge barrier.
That's a critical point. The solution lies in standardized protocols and co-management models. We use tools like ESTA-PP-FALL, a comprehensive screening list designed to identify fall risk-increasing drugs, or LIDs. The key is to embed the medication review process directly into the fall bundle, requiring a formal consultation with pharmacy or a dedicated nurse care manager to propose a taper or substitution.
So it shifts the process from an individual physician's reactive choice to a systematic team-based protocol.
Precisely. It reduces the individual liability and increases adherence.
Okay, so moving beyond pharmacology, we turn to physiological and functional deficits, which represent enormous modifiable targets. The data here is perhaps the most shocking.
It is. The single strongest modifiable functional risk factor is gait and balance deficits, boasting a massive adjusted OR of 9.0.
An OR of 9. I mean, think about the clinical magnitude of that.
It's incredible. A patient with a documented gait deficit is 9 times more likely to fall than a comparable patient without one. This powerfully emphasizes the role of aggressive, targeted physical therapy and rehabilitation starting the moment the patient is admitted.
And simply ordering a PT consult is often insufficient.
It's not enough. The intervention must be sustained, supervised, and tailored to the specific deficits identified in the assessment.
Other physiological factors we can manage include orthostatic hypotension, which is modifiable through meticulous medication timing, hydration management, and patient education on positional changes. And we must not overlook delirium.
Delirium is a critical, highly preventable risk factor for falls, and often an underdiagnosed cause of that unanticipated physiological fall. Effective delirium management requires multi-domain strategies, cognitive stimulation, early mobilization, optimizing sleep hygiene by minimizing nighttime disruptions, and managing fluid and electrolyte imbalances.
So when you manage delirium well, the fall rate drops.
Significantly,
Yeah.
because you are addressing the underlying cognitive instability.
Finally, let's look at the environmental and care factors, where system interventions can yield immediate results. There is a fascinating, yet unsettling paradox regarding activity restrictions that directly challenges historical practice.
The study data is definitive here. Patients who were ordered up with assistance, intended as a conservative measure, actually had significantly higher fall rates, an adjusted OR of 8.7 than those given full bathroom privileges.
That's almost as high as the gait deficit OR. We have to ask, why are overly restrictive orders so counterproductive?
It's a loss of patient autonomy combined with the fear of burdening staff. If a patient feels a pressing need-like urgency due to a diuretic and knows they must wait 10 or 15 minutes for assistance,
They'll just try to go on their own.
exactly. The perceived risk of falling during a rapid, covert, unassisted trip to the commode is weighed against the distress of waiting. The restriction turns a necessary biological need into a high-risk mission.
So this forces us to use balanced mobility protocols that prioritize scheduled, supervised mobility over punitive or overly conservative blanket restrictions.
Absolutely. We also know system factors play a role. High patient-to-nurse ratios are associated with increased fall risk, an adjusted RR of 1.6 per unit increase.
And while we can't solve staffing shortages instantly, we can implement systemic modifications like scheduled toiling programs to ensure that high-risk transfers are supervised.
Right, particularly for patients with urinary frequency or incontinence, which itself has an adjusted OR of 2.3.
This recognition of multifactorial risk means we must implement a guideline-driven approach to assessment. We have to stop relying solely on scored fall risk tools.
We do. Tools like the Morse Fall Scale often suffer from poor sensitivity and high false positive rates, and crucially, they don't provide tailored intervention guidance. A patient with a high score needs more than a badge. They need a specific plan.
Exactly. The American Geriatric Society and World Guidelines advocate a two-tiered strategy. First, brief screening on admission. Second, a comprehensive multifactorial assessment only for those who screen positive or are already known to be high risk.
This preserves nursing resources for those who need personalized plans.
So the initial screening should be rapid and standardized.
It should. We strongly recommend the CDC Steady 3 key questions, which can be quickly administered by nursing staff or intake personnel. Do you feel unsteady when standing or walking? Do you have any worries about falling? And have you fallen in the past year?
And a positive response to any single question flags the patient as high risk.
Correct, and that warrants the next level of assessment.
We also have patients who automatically bypass this initial screen entirely. This is essential for efficiency.
It is. If a patient presents with a fall-related injury, has documented 2 or more falls in the prior year, exhibits signs of frailty, has already had a fall during this hospitalization, or has severe cognitive impairment, they proceed directly to comprehensive evaluation.
Once screened positive, the next step is objective functional assessment.
Right. And the gold standard for hospitalized patients, even those with limited mobility, remains the timed up and go, or TOGI test.
Let's unpack the TOGI test for our listeners. It involves the patient rising from a chair, walking 3 meters, turning around, walking back, and sitting down. Why is this considered the gold standard?
Because it is a global measure of functional status. It assesses multiple aspects of mobility simultaneously: the strength for the transfer, dynamic balance during ambulation, turning agility, and gait stability.
And a TOGI time over 12 seconds indicates significantly increased risk.
It does. If the TOG isn't feasible, alternatives include the 30-second chair stand test or the 4-stage balance test. But the key is that the assessment must be objective and measurable, providing the data needed to personalize the mobility component of the prevention plan.
The comprehensive multifactorial assessment is where we consolidate all these dynamic risk factors. This goes far beyond just ticking boxes on a scale.
Absolutely. We must systematically include a detailed fall history, not just that they fell, but the mechanism, frequency, and injuries sustained.
And a thorough medication review, using tools like STOPP fall.
Yes. And checking the ACB score. A cardiovascular assessment, crucially including lying and standing orthostatic blood pressure checks done at 1 and 3 minutes. A physical exam covering gait, lower extremity muscle strength, visual acuity, and feet health.
And cognitive function, including active screening for delirium with a tool like CAM.
Correct. As well as evaluation of the patient's fear of falling, often using the FESI scale. And finally, a detailed assessment of environmental factors within the hospital room itself.
And a practical note on terminology, again from the AGS, we should use average risk for those who screen negative and increased risk for those who screen positive.
Right. We should strictly avoid using terms like low risk or not at risk, because we know that even in the average risk cohort, 20 to 30% of individuals still experience a fall annually.
We're only assessing increased risk relative to the average hospitalized patient.
Exactly. And crucially, every fall necessitates an immediate and systematic post-fall assessment. This isn't just paperwork. It is essential for both immediate patient safety and institutional QI. We have to determine the specific mechanism of the event, assess the resulting injuries, identify the precipitating factors, was it new illness, new delirium, a med change, and immediately adjust the personalized intervention strategy based on that event.
Now we get to the core prevention strategy, the actions that truly move the needle. The single most important finding in the last decade of fall prevention research is the established efficacy of multifactorial intervention bundles.
That's right. This is not about a single magic bullet, but a personalized combination of interventions tailored to the patient's specific risks.
And the evidence base is now robust.
It is. When these bundles are truly tailored to the patient's specific risk profile and delivered with high staff engagement and consistency, they probably reduce both the rate of falls and the risk of falling. This is considered moderate certainty evidence.
And the effect size is significant.
It is. Specifically, tailored interventions delivered consistently show a significant ratio reduction, or RAR, down to 0.61. That's a 39% reduction in falls when the interventions are personalized.
Let's detail the effective elements that must be included in a robust, evidence-based bundle. First, exercise and mobility. What does the data tell us about the required intensity?
The data tells us that exercise must be supervised, individualized, and critically sustained. If active, supervised balance training and strength exercises targeted to the specific deficits from the TUG test are not maintained consistently throughout the hospitalization and continued into discharge planning, the effect on fall rates is rapidly lost.
So it requires dedicated PT and OT time?
And reinforcement from nursing staff during ambulation. Second, the medication review and optimization process we discussed must be formalized within the bundle.
Right, systematic deprescribing of varieties, particularly psychotropics.
Yes, using standardized protocols like STRIDE. These protocols often necessitate nurse co-management models. A dedicated RN acts as a fall care manager, coordinating the individualized care plan, which then goes to the physician for final medication approval.
It's that systemic approach that's essential for overcoming clinical inertia.
It is. Third, education. This is often undervalued, but it provides the strongest hospital-specific evidence, reducing fall rates by an impressive ratio of 0.70.
And this education must be multi-pronged.
It has to be. It targets patients, families, and staff. It's not just telling a patient, don't fall, it's teaching them about their specific risk factors. For example, this new diuretic will cause urgency, so please use the call light before the urge is severe. It's outlining prevention strategies, ensuring safe mobility expectations are met, and incorporating motivational interviewing to ensure patient compliance and buy-in rather than just imposing rules.
Fourth, delirium management must be integrated as a core fall prevention mechanism, not just a psychiatric complication.
Absolutely. The integration of multi-domain strategies, cognitive stimulation, daily orientation checks, early and structured mobilization, meticulous fluid management, and optimizing sleep hygiene directly addresses a major preventable physiological cause of falls.
Good cognitive care is good fall prevention.
It is. And finally, nutritional support. What role does nutrition play? Specifically, vitamin D supplementation for patients who are found to be deficient probably reduces the rate of falls by a rate ratio of 0.72. It's a simple, quantifiable intervention.
And dietary changes.
Dietary changes, such as increased protein and calcium intake guided by a dietitian, may decrease fracture risk by a relative risk of 0.67, addressing the severity of the injury, not just the incidence of the fall.
The implementation success of these complex bundles hinges on seamless system changes. We can't just mandate these, we need the infrastructure.
Precisely. Nurse co-management models, where a dedicated RN coordinates the individualized plan, have been shown to ensure the care plan is dynamic, consistently documented, and executed across all 3 shifts. This often requires specialized software or EHR tools to document the individual risk factors and trigger the appropriate tailored interventions rather than relying on generic unit-wide protocols.
Let's transition now to a tough but necessary conversation. The interventions that often persist in clinical practice despite overwhelming evidence suggesting they are ineffective or counterproductive. We have to apply a critical lens to historical practice.
We must start with physical restraints. There is a massive, uncomfortable evidence gap here. There is not a single randomized controlled trial that supports the safety or efficacy of physical restraints for fall prevention.
In fact, the observational data points to worse outcomes.
Exactly. Observational studies consistently show that restraint use is associated with a longer length of stay, increased agitation, higher use of psychotropic medication, and critically, an increased risk for delirium and disorientation.
So the patient is often restrained to prevent a fall, only to develop delirium, which is itself a major sustained fall risk factor.
The paradox deepens when you look at how they're justified. Restraints are often implemented for fall prevention, yet injurious fallers who had physical restraints actually fell later in their hospital stay and had longer lengths of stay compared to those without restraints.
The evidence just doesn't support their primary purported purpose.
It doesn't. Next are device-based interventions, specifically bed and chair sensor alarms. This is perhaps the intervention where institutional comfort level most overrides the evidence.
The data here shows significant uncertainty. Meta-analyses found very low-quality evidence that bed and chair sensor alarms affect fall rates or the risk of falling.
And the consensus groups remain uncertain about the effectiveness of alarms, bed rails, and even specialized grip socks.
Why are they so ineffective?
Well, it stems from several factors, most prominently alarm fatigue. Staff often become desensitized to the constant noise, leading to delayed response times. More fundamentally, the alarm only alerts staff after the patient has already initiated the risky behavior.
After they're already getting out of bed.
Right. It does nothing to address the root cause, whether it's urgency, pain, or delirium. It's a reactive device in a proactive environment.
And finally, constant observers or sitters. This is a high-cost intervention that consumes substantial resources. What does the evidence say?
Evidence of effectiveness is scant and very low certainty. There have been no randomized trials demonstrating their efficacy for fall reduction. Sitters are extremely expensive, yet often struggle to prevent falls in patients who are highly agitated or determined to mobilize, frequently leading to a situation where the fall still occurs, but now the hospital has absorbed the high cost of the sitter.
This highlights a major resource allocation dilemma. Why spend thousands of dollars on an intervention with such low certainty of benefit?
Exactly. In contrast, we are seeing evidence suggesting that non-contact, continuous video monitoring may be a more cost-effective and equally, or perhaps more effective alternative.
Right. Video monitoring can reduce sitter use without affecting falls.
Or even reducing them. This brings us back to the central controversy. Why do these interventions, restraints, alarms, sitters persist?
It's driven by perceived safety, aggressive marketing, liability concerns, and deep-seated historical practice.
We have to challenge the institutional reliance on these non-consensus measures and redirect those resources toward the high-yield, individualized care bundles that are proven to reduce harm.
When, inevitably, a fall does occur, the immediate clinical response is paramount, followed by a rigorous quality improvement cycle. The first step is immediate, comprehensive head-to-toe injury assessment.
We must operate under the assumption of injury until proven otherwise. Patient history can be profoundly inaccurate, particularly in older adults with cognitive impairment or dementia who can't reliably recall the event or localize pain. The physical exam can also be deceiving.
So if there's any high suspicion for injury, particularly in patients with coagulopathy, known risk factors for subdural hematoma or severe cognitive impairment, a lower threshold for aggressive imaging is warranted.
It is. This sometimes means considering a pan scan, a whole-body CT, to evaluate the head, cervical spine, chest, abdomen, and pelvis to definitively rule out serious occult injuries like a subdural hemorrhage or an internal fracture.
Once the immediate injury is managed, the systematic post-fall evaluation begins. This assessment must be targeted at identifying the new precipitating factors.
Right. Was it acute illness? A new onset of A-flutter? A complication of a medication? This immediately transitions into the quality improvement cycle via a root cause analysis, or RCA.
And RCA is vital because it shifts the focus from individual patient behavior to systemic failure points.
Exactly. For instance, an RCA at one institution found that the highest frequency of falls occurred between 10 p.m. and 7 a.m., confirming that peak fall time, and that diuretics and induced hyperdiuresis were contributing factors in 80% of falls, with antihypertensive medications involved in 1/3 of cases.
And translating those RCA findings into actionable QI is the essence of effective system change.
Right. The response to that data is practical and targeted, rescheduling diuretic and antihypertensive drugs to mitigate the nighttime risk, ensuring the peak diuresis occurs during waking, supervised hours rather than in the dark when the patient is confused and unassisted.
That's a far more effective intervention than a generic bed alarm.
Much more effective. Standardizing communication around the individualized plan is also a high-yield QI strategy. We need consistency across all shifts.
And there are tools for that.
There are. Tools like the Fall Tailoring Interventions for Patient Safety or Fall Tip Pest Toolkit have demonstrated high efficacy. This is a nurse-led, evidence-based intervention that standardizes the 3-step prevention process. First, assessing the specific risk factors. Second, creating a personalized plan. And third, executing and communicating that plan consistently using a visual bedside communication board.
And the results are impressive.
Clinical trials using fall tips have demonstrated a 25% reduction in patient falls. This just shows the power of personalized consistency.
Finally, the fall prevention cycle must not end at the hospital door. We have to embed this entire process into discharge planning.
This is a critical final step. All patients who have suffered a fall during their hospitalization must receive a comprehensive evaluation by physical therapy and occupational therapy prior to discharge. We need an objective measure of functional status.
So a safety assessment, including a documented gait evaluation and, ideally, a repeat tug test, must be performed before the patient leaves.
It must. If that safety assessment reveals that the patient is unable to rise from the bed, turn, and steadily ambulate, or if their safety cannot be reliably ensured at home due to unaddressed deficits, then a reassessment of the discharge plan is mandatory.
Which might include consideration for admission to a short-term rehab or a skilled nursing facility.
Exactly. Our duty extends to ensuring functional safety post-acute care.
To summarize our deep dive, the critical takeaway for our hospital medicine peers is that effective fall prevention in the acute care setting is not about relying on generic protocols, non-consensus interventions like restraints or ineffective alarms, or simply ticking boxes on a risk score.
It is entirely about personalized, dynamic, multifactorial interventions anchored by systematic medication review using tools like Sesto-PP Fall, supervised and sustained exercise tailored to functional deficits, comprehensive and motivational staff and patient education, and aggressive, proactive cognitive health management focusing on delirium prevention.
This holistic approach is the only way to achieve the rate reductions mandated by the evidence.
And the central tension in hospital medicine that we must all constantly manage is the balance between promoting mobility, which is essential for maintaining functional independence, particularly in very frail older adults, and simultaneously mitigating the high acute risk of falling. We have to continuously apply critical thinking regarding which activity restrictions truly protect patients and which, paradoxically, increase their risk by fostering unassisted, high-risk behavior in secret. We urge you to critically review your institution's reliance on non-consensus interventions like alarms and restraints, measures that consume vast resources yet lack evidence of efficacy, and shift those resources immediately toward high-yield, individualized care bundles.
Thank you for joining this deep dive into hospital falls.